Welcome to today's Catalight webinar, The Importance of Differential Diagnosis in Autism. One size doesn't fit all. I'm Chris Larson, reporter for Behavioral Health Business. I've been covering the healthcare sector since 2016, and I'm excited to be moderating our conversation today. During this webinar, we'll discuss Catalight's perspective that differential diagnoses are critical to an effective, personalized autism spectrum disorder treatment program. We'll save 15 minutes at the end of today's webinar for audience Q&A, so please enter your questions into the Q&A window during the webinar. Our panel will answer as many as possible today after the discussion. Also, in the resources widget, you'll find Catalight's latest white paper on new behaviors in behavioral health, as well as a post-webinar survey. Please take a minute after the webinar to share your feedback on today's webinar. Joining us today are Catalight's Chief Clinical Officer, Dr. Doreen Samelson, and Dr. Stephen Kanne, Director of the Center for Autism and the Developing Brain, and Assistant Professor of Psychology in Clinical Psychiatry at Weill Cornell Medical College and New York-Presbyterian Hospital. Doreen and Stephen, can you tell us more about your backgrounds and respective roles? Doreen, why don't you go ahead and kick us off?
Thanks so much, Chris. So I'm a licensed clinical psychologist. As you said, I am the Chief Clinical Officer for Catalight. I also lead our research institute. And it's been just a great pleasure for me to be with Catalight almost 7 years now and be able to really do the research into autism and other related developmental disabilities.
Hi, can I go ahead and Taylor?
Yeah,
My name is Steve
ahead,
Kanne. Yeah, I'm the director for the Center for Autism and the Developing Brain here at Weill Cornell, a professor at Cornell as well. I'm a pediatric neuropsychologist by training, a clinician. I see many kids for a question of is autism present or not? And I do a lot of research in the phenotypic variability of autism and developing new measures in autism. And thank you for inviting me to this webinar. I appreciate it.
Hey, it's our pleasure to have you. Let's go ahead and dive in. So first, can you talk about the prevalence of autism in the United States and why we've seen rates on the rise? Doreen, why don't you go ahead and take a first crack at that?
Thanks, Chris. You know, that's such a good question. It's also a very complex question. And I have to say, to begin with, we don't know all the factors that go into the prevalence rates rising like they have. I met my first autistic child in 1982, and at that time, the prevalence rates were about 1 in 2,500. Now we're 1 in 36 in the nation in the United States, and I'm sitting in California where we're 1 in 22 4-year-olds and 1 in 22 8-year-olds carry a diagnosis of autism spectrum disorder. And that's one of the things that have changed, right? We went from autism as a diagnosis to this diagnosis of autism spectrum disorder, and we folded in some other disorders that were actually not part of a spectrum because we didn't have a spectrum. Things like Asperger's was a separate disorder, considered a separate disorder in the past. Now it is folded into this spectrum. There's certainly been more, I think, awareness and people know more about autism. So parents might be looking for signs and go to their pediatrician and say, you know, I'm a little bit worried. The other thing that's happened that has really increased the heterogeneity or the variety of kids and adults that we see under the spectrum diagnosis is that we're seeing a lot of kids with known genetic disorders. A classic one would be Fragile X. Fragile X in boys is associated with autism spectrum disorder. When I first started out early in the 1980s, we knew about Fragile X, but we didn't consider Fragile X to be part of autism. So we considered it to be, you know, completely separate. But now we have a whole group of kids that have genetic syndromes, including things like Fragile X or deletions on chromosomes. And many of those kids are also being diagnosed with autism. So it's complicated. We don't know all the reasons why, but you're certainly right in terms of the prevalence rate as it's reported. Autism has increased greatly. And I wonder if Dr. Kanne has some things to add to that.
Yeah, I mean, that's a very comprehensive answer. I think, you know, the way I think about it is people, my epidemiologist friends who do a lot of research, they really think that, you know, if you look historically, the prevalence overall probably hasn't changed, believe it or not. But what has happened is we used to define autism in this really narrow bucket, right? And now over the years, as Doreen was alluding to, we expanded that diagnostic bucket to include other things, other disorders that are very appropriately fitting in that bucket. But now we're actually recognizing them when they weren't recognized before, which I think is why we keep on seeing the rates jump up. I think a great example, if you look at the most recent numbers too, is the prevalence rates of non-majority children, Black children, Asian children, have jumped up over the last 4 years. Does that mean that suddenly there's more of them that have autism? No, it means that we've done a better job, as Doreen alluded to, with awareness and access to care, because there have been some focused efforts to do that. I mean, on a personal, I just got done watching Love on the Spectrum just the other night, and I'm like, it's everywhere. I mean, every TV program there's like 3 or 4 TV programs right now that feature autism somewhere in them. So I think it's increased awareness, it's increased diagnostic variability with regard to who we're including in that bucket.
I gotcha. So let's understand a little bit more about what the difference is between the social and the medical models of autism. And Dr. Kanne, let's go ahead and stay with you for the first crack at that answer.
Yeah, I mean, I think this is such an important topic to cover up front in this webinar because it's become an important topic in our field, and one that's near and dear to many of our hearts. And this is the notion of neurodiversity and being able to be appropriate and respectful of the population that we work with. So what we mean by that is a social model of autism includes things like autism is my identity, which is part of the neurodiversity movement. That's much different than a medical model. And I think this affects the language that we use when we talk about autistic individuals. This affects the way we write about them. This is the way we do research. So we want nothing about us without us is the term. We want to include autistic individuals in all of our research, in all of our conversations, and all of our thoughts about intervention. But the problem, quite honestly, is there's a wide range of voices, even within the autistic community. So there's really no consensus on what language we should use in total. The other problem is when someone comes to my clinic, a parent, they're coming under the medical model, which is I'm coming to this place to find out there's something going on with my child. My child is experiencing challenges that I need help with. So that's much different than the social model. What is your child's identity? It's more the medical model, like, okay, what behaviors, what symptoms are you showing? And what can I do as a clinician to help let your child become the best version of themselves they can be? What that means is I have to function under a medical model with words like impairment and severity and symptoms. I have to write a report that actually talks about those things and actually doesn't emphasize strengths, because then the families won't get the services that they need because insurance companies and others will not honor those claims. So there's a tension in our field between both. And I think we've learned a lot from the movement, and I think we need to be open to all sides and be respectful of every individual that comes to your door and where they might be coming from. Doreen, do you have stuff to add to that? Or?
Yeah, thanks, Stephen. I agree with what you said. And I think it can be very confusing, though, for families and even for autistic individuals, because there is such a varying number of needs in the broader community. I'm glad you mentioned the thing about identity, because some people will identify as identity first, autistic person. Other people will say, no, I'm a person with autism. And that goes through the disability community. As a wheelchair user, I do identify as disabled. But other people would say, no, I identify as a person with a disability. So there's a lot of personal choice in this. It can be very confusing for families. And you're absolutely right. When we're working in the medical model, where we're trying to get authorizations for treatment or for services that somebody needs, that's very important. We need to make a diagnosis. And so we're sort of stuck with using terms like disorder. But we do need to be respectful, because I know that some of the autistic adults who are advocates don't like the term disorder. They would prefer a different term than disorder. So, it's really balancing those different perspectives and allowing people to have choice in terms of how they think about themselves.
I gotcha. And diagnosis is definitely a part of that. So, Dr. Samelson, why don't you go ahead and explain exactly what a differential diagnosis is?
Well, a differential diagnosis particularly in developmental disabilities or disorders is to see which diagnosis really fits the person's, I'm going to use the term symptoms because we're talking medical model right now. So really fits the person's behavior and symptoms. So there's a lot of different developmental disabilities, right? And unfortunately, I think sometimes it's been a good thing that we have more awareness of autism, but the negative part of that is sometimes we forget that there's a whole bunch of other developmental disabilities out there, and maybe they sort of get lost in the discussions around autism. And the other thing is that a lot of our kids have not just one condition, but multiple conditions. So in a differential diagnostic, we really need to not just look at autism, but we need to determine whether the child has an intellectual disability. And we know that a child that has an intellectual disability and autism is going to probably have much higher needs and probably have needs in terms of services down the road when they're an adult. And as they're an aging adult, they're going to need different services as well. ADHD is another condition that can occur with autism. And actually, there's a fairly big overlap between autism and ADHD in some studies. I think one of the things that is so critical is that what we found is that lots of times we are ignoring the intellectual disability. And Audrey Thurm, if I can just say, she's speaking at the Catalight conference next week. I think there's still time to register for that virtual conference if you go to catalight.org. But Audrey Thurm, Dr. Thurm is at the NIH, and she published a really important study in 2019 showing that as the prevalence rates or the diagnosis of autism was going up, the diagnosis of intellectual disability was going down. Now, that really doesn't clinically make a lot of sense. And what we think is that we have children with both conditions, and we are missing the intellectual disability condition in some of our autistic children. So what we want to do in a differential diagnosis is really make sure that we're making the right diagnosis, and that diagnosis is going to really inform us for services and perhaps treatment that that child or adult needs. And Stephen, you may have something to add to that as well.
Yeah, no, well said. I think I can speak as a clinician that does diagnosis primarily. When someone comes through my door, the way I kind of think about it is, my job under the medical model again, and it is diagnostic differentiation is the medical model, just so we can be clear about that. They'll come in, I throw up these diagnostic balls into the air. It's like, what am I seeing in front of me? What can explain from my conceptualization what behaviors I'm seeing, what symptoms I'm seeing? Maybe it's ADHD, maybe it's social anxiety, maybe it's selective mutism, maybe it's a seizure disorder. So all these balls jump up in the air. And then through the tools that we have and the assessments that we do and the expertise that we've developed, we're able to say, well, no, ADHD doesn't really account for everything, and depression doesn't really account for this either. So that's the process of differential diagnoses, is being able to use our tools, our interviewing, all the data we can get at hand to really say what is actually going on with this child or adult. I think one thing Doreen was speaking about, there's this term which I love to use. It's kind of a cool set of words. It's diagnostic overshadowing. It's such a cool term. And what this means is that if I have a child come to me and all I can see is ADHD running around, they're doing all this stuff, that diagnosis takes over. I don't see the other diagnoses that might be there. So this could happen with autism and intellectual disability. All I see in front of me is the autism. That's why they came to me. And I just ascribe inappropriately all of the symptoms I'm seeing to the autism, when in fact, as a good clinician, I should say, wait, in the presence of autism, what else might be going on? Because we'll talk, I think, later on about like why it's important to identify all of these other things that might be going on with the child to help send them in the right direction, provide the right supports for them.
I gotcha. And Dr. Kanne, what does this work look like? So what does that diagnostic process look like?
Sure. I always like to start to answer that question with the two main elements. If the question is, and which it usually is when you come see me, does my child, or am I as an adult, do I have or does my child have autism? There are two main components that we look for an evidence-based approach. I say that on purpose because there are many people out there who don't take evidence-based approaches, and that's something that we disagree with. We really think to do a good quality evaluation, you need to use the best tools and have the best training to be able to make that. These diagnoses, this visit are things that parents remember for the rest of their lives. I mean, they remember, I had a parent come up to me and said, 10 years ago, I remember exactly what you told me, which is kind of weighty and humbling. So you want to make sure that you do, even though, I see 100 patients, a year, it's like, no, this is a moment for that family that I need to take special care with. So what that means is for a diagnosis of autism, I have to do two main components, which is direct observation and interaction. I need to be able to see and interact with that child, and I need to get the right developmental history. So those are the main components of an autism diagnostic process. How do I assess in the moment, are they showing the behaviors and symptoms and challenges that we know are aligned with autism? But then they also have to have the developmental history that also aligns with that. If they only started showing these symptoms when they're 9, that's not autism. Autism is presumed to have when you're born with it. It's just when the symptoms manifest over time. So there are tools that have been developed across many years now, since probably the mid-'80s, that are now been refined to do a very, very good job of helping us understand if the person has autism or not. And I don't want to like say all the tools are. It's kind of a boring, all these acronyms, but I want to stress the fact that these are only tools. The gold standard in diagnosing autism is the clinician. So you can't just go with what a test tells you, just like you wouldn't in a lab test or any other test. I, as a clinician, have to have the proper training, the proper experience with neurotypical kids, with neurodiverse kids, to be able to interpret those measures and answer the question if that person has autism or not. So the diagnostic process could be over a couple days. It could be a single day. It depends on what you're presenting with and the clinics that you go to. But they're going to have the elements that look at autistic symptomatology, usually developmental or cognitive functioning, things like adaptive skills. How do they do in the real world out there? Emotional and behavioral functioning, like are there depression or anxiety, internalizing or externalizing symptoms? And you do this through a variety of means, try to gather it from school, from the parents, and from your own observations. You put it all together, and then that's how you make your diagnosis. But Doreen, is that similar to what you all do there? Or?
Yes, I think so. I think, what you described is correct. And there are many tools. And of course, observation is extremely important. And then sometimes I think we need to be careful to come back to that child or that family years later. Things do change. And there is at least one study out there that's showed that a large proportion of kids diagnosed very young with autism who did not have intellectual disability actually no longer meet the criteria when they're like 6, 7, 8 years old. And that's something new that we're just seeing in some of the research. And we don't know exactly what that means, but we do need to look at that, and we need to be very careful that we are, really not just making a quick diagnosis of ASD and moving on.
Yeah, and if I could comment on that too, Chris, it's like, historically, the historical data, there's always been across all the studies about 10% of the kids improve. They've been called different things over the years that Doreen are probably aware of: optimal, functioning, recovered kids. And it's interesting that one study came out that is a little bit higher than that. And the question is what techniques they do, how is it replicated? So we do need to look closely. I think for me, the important thing with that is it is really a different conceptualization of autism, meaning though, like if they perform in that one day outside of the range of our behavioral criteria, does that mean they don't have autism anymore? Because what I find working with people longitudinally, especially the kids who don't have intellectual disability, is they're still like on the edge of things. They still, in certain circumstances, encounter problems. And I always think about like a speech language disorder. If you have one when you're young, you work with a speech language therapist and they help you say, I can't even tell. But now I'm in a public speaking environment, things are higher pressure, it might pop out. I might be more vulnerable to speech language problems. So it's this really, I push back against this categorization of, do you have autism or don't you? Because we've made up these borders, right? So for me, it's like, do they meet criteria? If they don't, are they still having challenges? And in some sense, this is weird to say, but who cares about the diagnosis? Let's just make sure they get the help they need to overcome whatever challenges they have.
If I could just add to that, because what popped into my head when you said, you see someone who's actually, it looks like they're functioning pretty well, but you see some little things and it's true, stutterers. And we have a president now who's a lifelong stutterer, and stutterers often say the wrong word, usually the wrong noun. And that's a part of stuttering. And if you're a stutterer, you always have to be careful not to do that. And you're probably going to do it sometimes, right? And then if you happen to be a famous person, you get fingers pointed at you for doing it. But it's true, people who have different developmental conditions or neurodivergent conditions are going to still have some of those remaining aspects. And it may be disabling or maybe not disabling. And I think that's another issue is what is disabling and what is it? We don't want everybody to be the same, and we like people to be different, and that's fine. So there's it's kind of a difficult distinction sometimes.
Agree totally.
Right. In addressing distinctions, not exactly what you said, but that's my understanding is why differential diagnoses are important in ASD. So Doreen, why don't you go ahead and answer that question for us? Why is a differential diagnosis important in ASD? And then what happens in the event of an incomplete or incorrect diagnosis?
Well, I think one of the things that we're seeing in terms of an incomplete diagnosis is youth and young adults who were not diagnosed with ID, but were diagnosed with autism when they were young. And as they're moving into adulthood and they need more significant intensive supports, they may need to go into a residential program like an adult day program or a supported living program, something like that. And they are losing some of their benefits, perhaps, because they have a diagnosis of autism, but not a diagnosis of intellectual disability. So unfortunately, I don't like it this way, but some services are tied to the diagnosis that the person has. And so we are seeing youth and adults who were not assessed for cognitive abilities or for an intellectual disability when they were young, but did have an autism diagnosis when they were young, now coming back and wanting to be evaluated for intellectual disability for the purposes of making sure that those services and supports that they need as adult. And one of the things I always say is, we're adults longer than we are young children, right? So we have a lot, and the disabled community, including the developmentally disabled community, is living longer now. So many people need those lifelong services. So it's very important that we don't have incomplete diagnoses. In terms of misdiagnoses, I think there is sometimes a problem between things like autism and ADHD, and it might, be a diagnosis that's missed, like it might be more ADHD and not autism. And then, we're not addressing the ADHD. So that's why, we want to be really careful. As long as we're in a medical model and as long as services are tied to a diagnosis, like it or not, we do need to be careful about the diagnosis. I don't know, Stephen, if you have anything to add to that.
Yeah, a couple of things. Again, well said. For me, I'm reminded of a couple of papers I've read recently on autistic adults who reflect back on their own diagnosis. And beyond the great majority, if not 100%, said, no, we wanted the diagnosis. We appreciated getting it as soon as possible, because it was explanatory for them as to why they were struggling in certain areas. So even moving a little bit, dipping our toes into the social model, it's important to get a correct diagnosis if you actually have autism to help with understanding yourself as to why. Another reason that seems more bald-faced but is incredibly important is if we have a lot of incorrect diagnoses out there, then it really hurts our ability on the scientific side to do a better job of understanding how to help autistic individuals, whether it be through any type of research. If I do research looking at intervention that includes a whole bunch of people that aren't autistic, well, then how am I really proving if that treatment actually works or not? It's like testing a cancer drug with, a bunch of people that don't have cancer. Your results are going to be messed up. So there are many, many important reasons why a correct diagnosis is so important.
I'm glad you mentioned the research angle. You're absolutely right about that. That is becoming an increasing problem, actually.
Yeah.
I got you. Shifting gears just a little bit. I've already talked about a little bit about the stakes, but also the natural results that come with the diagnostic process. So then, what is behind the shift towards using a more comprehensive diagnostic process? And Dr. Kanne, can you kick us off there?
Yeah, it's interesting. I was reflecting on that. It's like, I'm not sure if there's a shift in that. except for the reasons that Doreen has already, explained about the making sure we understand that it's not diagnostic overshadowing or something. I think for me, I'll answer this question a different way, and then I'll let Doreen answer it a different way. For me, I think there's been this emphasis lately. I'm a part of this is developing technologies that allow us to make diagnoses quicker. A mobile phone, a screening device that somehow I can make this diagnosis very quickly. And there are many reasons we want to do that. In many parts of the world, they don't have access to the type of experts in care. So we want to be able to make it accessible to everybody. The only problem I have with that, and I'm one of the big proponents of pushing back against that, is, if you can imagine walking into Walgreens and sticking your arm in a blood pressure machine and it says, oh, you have autism. To me, there's so much more to working with a family than just, do you have autism or not? There's understanding the family, understanding where their needs are. It is a therapeutic moment for that family to understand their needs, their processes. For me, it is important to get the diagnosis correct. Obviously, that's what I do. But it's more important to understand the family and that child and what their needs are in total so I can help them. You're not going to get that from a non-comprehensive evaluation. Some parents, by the way, that's all they do need. And I acknowledge that. They're like, no, I got this. All I need is it autism or not so I can access services. Others are like, I don't know what to do. Where do I go? How do I navigate this system of care? What about IEPs? What about medical? So they need a team behind them that's able to help approach that. Doreen, I'm curious to your take.
Yeah, one of the groups that I think about is those individuals and families where you have what is sometimes now called profound autism, which is not an actual diagnosis, but it's characterized. We're talking about someone with an IQ under 50, minimal language, often very difficult, disruptive, and dangerous behaviors. Those families really have to understand the needs for their children. They really need a comprehensive diagnostic to understand their child's language abilities. Or when you have minimal language, it's very different than when you have full complex language. And, without a real careful diagnostic, just saying, oh, your child has autism is not going to be enough for those families. I would also say for those individuals who are autistic, who also have ADHD, they need to understand the ADHD too. It's the overshadowing that you mentioned. It's like, it's not always the autism. It could be the ADHD. So it is important. And all of us, we want to understand ourselves better in order to function better. And that goes for our children as well.
I got you. And moving on to our next question. So it sounds like we've answered the answer to our first question is yes. Is differential diagnosis important to other developmental disabilities as well? It's a conversation, obviously, but why is that? Is there anything else to add? Maybe outside of the realm of the diagnostic overshadowing. And Dr. Samelson, can you share maybe another thought, and then we'll go and move on.
Yeah, Chris, I'm not sure I completely understood the beginning of the question. I'm sorry.
Right. So is differential diagnosis important to other developmental disabilities as well?
Oh, yes.
And why is
yes. Yes, absolutely. And here's the other thing that we're seeing. Now I'm going to go back to the major genetic disorders. Okay. When I first was in a severely handicapped classroom, and I met my first child with autism and also kids with other disabilities, significant disabilities, Down syndrome and other developmental disabilities. We didn't know about all the genetic conditions. We knew about Fragile X. And Fragile X is a condition where there is an abnormal X chromosome, and it affects males much more than females, because as a female, I have 2 X chromosomes and a male only has 1. So if one of them is not operating, correctly, it causes a lot of problems. So now we know there's things like deletions on chromosomes, like 22q, which is a deletion on this 22nd chromosome. We didn't know about that before, but we know these conditions have a lot of very concerning symptoms that need to be addressed. For example, if you do have 22q, you're likely to have type 1 diabetes, and you may have a heart problem, and you're probably going to have problems learning. So we really do need to look at the whole, I think, we need to look at the whole developmental disability, the neurodevelopmental disabilities, and do, thorough assessments for any of the conditions that we see. And I do think it's important more and more to make sure that we're doing genetic studies. And I don't know, Stephen, if you have anything to add to that.
Yes, but it's a little bit off the side. That's okay. Because as you're speaking, like you're again absolutely right with the genetic piece. That's becomes so important. For me, when you were speaking, I was thinking about a girl that I saw, a little girl, like a couple weeks ago, and it made me think about exactly like this. So she presents with significant. She's very quiet, very sad, very anxious. And what we know from the sex difference type of research we've been doing is those are the type of girls that get missed. Because yeah, if you call it, disability might be a strong word. She was diagnosed with significant depression. But what was really happening is she had autism, and depression, but the autistic symptoms were what were affecting and impacting her life the most. But this is why we know, and all the data shows that girls are diagnosed later, especially girls that show significant internalizing symptoms that, again, mask the disorder. So there's lots of biases that go into diagnosing autism as well. We tend to see it in males more than females, and the symptoms they present with are slightly different. But I was just thinking about that too. It's like, oh yeah, there are other symptoms that you want to make sure that it's important to understand everything about that child and not miss those, because that diagnosis changed that person's life and the services she had access to.
Absolutely, I agree with that. Thank you.
Yep. Once a differential diagnosis has been made, how does that change the approach to the treatment plan? And Dr. Kanne, can you kick us off with that question?
Yeah, sure, a lot. And for many reasons, some good, some not so good. By not so good, I just mean the same thing Doreen was talking about. We're functioning under the context of a medical model in the United States under a very specific systemic kind of approach to medicine, right? So it is really, and I saw some of the questions in chat, it's really, really hard in our current system of care to access services without the proper diagnosis. And the reason why is you have to have that diagnosis, that you have to put the right code down, that code activates insurance, insurance can help you pay for the services. Now, if you're a billionaire and you can pay for your own services, that's different. But most of us aren't, and most of us have to go through insurance. So having that diagnosis, that label, in some ways opens up doors to treatment that you wouldn't be able to get. So that's one reason. I don't consider that a good reason, because that's more of a comment on our society and our systemic. I wish everyone could get the treatment they needed, basically, right? But the other reason I think, which is equally important, is it gives a roadmap for the parents and for that person to understand. Meaning, like I said, these autistic adults who say, oh, I got the diagnosis, this made a difference to me. I don't have to worry about, like, what am I doing wrong here and there? It's like, no, I actually know now if I'm autistic, then I need help here, here, and here. So it changed their own paradigm of how they saw themselves, and with parents, how they see their children. So they know, oh, this isn't just, worked with a teacher, it's like, oh, that's just a bad kid. I'm not trying to slam teachers, but they ascribed all this child's behaviors to being a bad kid. Oh my gosh, suddenly an accurate diagnosis, and like, oh, boom, it changes every way that you think about that child. And it doesn't excuse behaviors, but it helps you reconceptualize them in the context of which they're occurring, and can again lead to treatment in very much more accurate ways. So I think for me, and again, one final comment about that is, again, we just don't do, is it autism or not? We want to look at a range of different areas of functioning that includes all different areas. So their treatment plan could include many things that aren't just autistic specific. It could be speech language, it could be motor issues, it could be medication interventions, it could be peer supports, it could be therapy for the family, it could be a range of things depending on what our comprehensive evaluation shows. Doreen, add to that, please.
Yeah, no, I think you're absolutely right. I think one of the things that I think we're missing, in addition to missing the intellectual disability piece for some autistic individuals, is we're also ignoring the anxiety and depressive disorders, which are very common in the autistic population. And so, that if you get a diagnosis of autism and an anxiety disorder, and you don't have an intellectual disability, that might move you towards psychotherapy and maybe some medication, because you understand that those things are going to help you. So we are a medical model, and we do have services and treatments that are tied to a diagnosis. So we want people to be able to access those things, in our imperfect system here that we have. I agree with Stephen. I wish people could get what they need without all the special words that we write down on pieces of paper and send to insurance companies, but that's not the way it works. So it is important to make sure that we're not missing things, and that people have the opportunity to access services. I want to say one other thing in terms of the autistic population. Adults with autism who are job seekers may need to ask for reasonable accommodation, both in the interview process, the job seeking process, and on the job. And if they don't understand their autism, they don't have the diagnosis, they don't understand, they can't ask for those reasonable accommodations. So, it does all, follow people throughout their whole life, actually, when we talk about differential diagnostics.
I gotcha. So then let's talk about personalization. So how does the differential diagnostic process lead to greater personalization in care? And Dr. Samelson, can you address that question, please, first?
Well, I think it helps, but I think what really makes a difference is making sure that we're looking at what is important for that child or that adult in terms of improving their well-being. So what are the things that are going to be helpful to them? And well-being is really, where I think we need to go, right? If you're able to communicate better, your well-being is going to go up, for example. If you're not at risk for some dangerous behavior that could cause harm to yourself or others, then your well-being is going to go up and your family's well-being is going to go up too. So I think when we talk about, treatment, particularly behavioral health treatment, we really need to look at the individual and see what is the best plan and services for that person. I will say, and at Catalight, we certainly do ABA, and we do other things as well as ABA. And what we don't want is diagnosis autism, go straight to a certain type of ABA, and then you're done, right? There should not be some kind of a system like that, which unfortunately has happened a lot, where we're tying an individual treatment for everybody that has that particular diagnosis. And I think that is faulty. I'm not putting down ABA. It has its place. It can be very helpful, but it should not be the only option. And unfortunately, particularly for children, we've sort of had this knee-jerk reaction. Autism diagnosis, go straight to applied behavior analysis or ABA, and that is not effective. We need to look at the individual when we talk about services and treatment and see what the individual's needs are, and then tailor the services and treatment to that individual. And it might not be treatment. It could be something else, like an adult day program for somebody, which is really, an important service, but not necessarily a treatment. So it's an individualized process, I would say. And Stephen, I'm sure you have something to add.
I always have something to add, Doreen. I think the way I approach this, I would actually put it as a question to everyone in the audience. If I said, hey, walking through the door in 5 minutes is going to be an autistic 9-year-old. What does that tell you? It tells you nothing. You have no idea. Are they going to be speaking, non-speaking, brilliant, have an intellectual disability? Are they going to have stims? Are they not? Are they going to be depressed? And you have no idea. And this is why autism is much different than a lot of other disorders, where they're much more homogeneous. We're like, oh, I kind of know, what to expect, but in autism, you don't. So the need for personalized care is that much more extreme, because you have to, just saying they have autism doesn't really mean much. You need to understand that particular individual. So that's one of my answers. My other answer is that it reminds me of the big push these days. The big buzzword is precision medicine, right? Like, how do we, and that ties to genetics. So, and I always think about autism, like we are in the world of autism, much like the cancer world was in the 50s, where it's like,
Yes.
We knew what end stage cancer looked like, because it was very obvious to us. And that was the phenotype, if you will, of how they present it. But we didn't know much about how to treat it. We just threw everything we could at it, right? So now, think about it now. Like, if you unfortunately have encountered cancer in your own life in any way, you know that it's not that way anymore. It's like you do all these tests to say, what is the genetic condition that might be causing your cancer? And they've done so much research to be able to identify in a precision medicine point, like, if you have this genetic condition, yeah, we're calling it cancer, but this is the type of treatment that might help you the most. We understand the trajectory. We understand what treatments might work or not work. Here's your risks, et cetera. We are not there in autism. We're back in the 50s, right? So, but we understand that autism is a construct. There's not just one thing. They all have presumably a genetic basis that we are trying to understand. What are the trajectories? Like, can I identify, even though we're calling it autism, it really is what's causing it is this underlying genetic, whatever it might be. And what does that mean for treatment and trajectory, which involves personalized care again. So.
I gotcha. And Dr. Kanne, go ahead. And we're going to go stick with you to start off with our last planned question before we get to the Q&A. Can you tell us about the connection between differential diagnoses, the treatment plan, and what I assume will be improved care outcomes.
Yes. I just want to say that, oh my God, there are so many good questions coming through the chat. I wish that we could spend 4 hours just discussing all of those questions that are coming through chat. So, yeah, so I think we've covered pretty much in depth, why to do a differential diagnosis, what it means for a treatment plan. So what I want to talk about for a second is connection to improved outcomes. And I found this shocking and interesting if you look at some of the newest research that's coming out. And Doreen did a really good job of saying, well, what we're interested the most is in well-being, on how do we judge a good outcome? So that's where to start with that question. What do you mean, Chris, by a good outcome? Does that mean you have a job? Does that mean you're happy? Does that mean you're married? Does that mean, what does it mean, right? So, and especially in the world of autism, good outcome, because it's so heterogeneous, can mean so many things. I was talking to one mom where the good outcome was her child said, "I love you, Mom," for the first time ever. To another mom, a good outcome was my 19-year-old has a job now. So good outcome is such a moving target. So that's the first thing. It's really hard to define that. But the way our society defines good outcome and well-being is like, again, how independent are you? How does society support you? Are you happy? Those types of things, quality of life, basically. And interestingly, what I'm going to summarize the research that's out there. What's super interesting is actually the autistic symptoms and their severity, if you will, how impactful the autism symptoms are, it doesn't rank very high up there in terms of good outcome. Not at all. Actually, like we give this kind of a quiz. What do you think would actually drive good outcome the most, the way we define it in these studies? Believe it or not, it was IQ points. That comes up the highest. Cognitive ability determines outcome and good outcomes the most. Second and third, believe it or not, are language, as Doreen alluded to. Communication is so important to outcome. And the last one, though, is so important too, and very interesting in our population of autistic individuals, is adaptive skills. The ability to live on your own, to do your own thing, daily living. Because you can have someone who's a 150, brilliant IQ, can talk, has his own radio talk show, but still can't live on their own, and it's mind-blowing. How is that possible? But it is in an autistic population. So those are the three main drivers of good outcome that we need to assess for interventions. And if I had to say, like, where are you going to spend your time, parent or adult, is getting those things better rather than like, should I stop stimming? Or should I like change my intonation of my voice that shows people I have autism? No, what's going to matter to your outcome are those things. Now, can we change IQ? No. But can you change things like ability to attend, create a different environment that's less sensory overload so I can attend to what's in front of me, which might lower my performance on IQ tests in other areas? Yes. So again, this is intersection between how we as a society can adapt conditions to make them optimal for functioning, but also target the right areas that have to do with impactful functioning that's going to drive outcome. Doreen.
Well, I'll just add something real quick because I want to get to some of these questions. There's excellent questions in the chat for sure. I think that thank you for mentioning the IQ or the cognitive abilities. I really, for those who have lower IQs and for those who have minimal language, we really can improve well-being. And I'm using the term well-being like, quality of life well-being. We use the term in Catalight well-being, but it's quality of life really. We can improve that with improvements in communication. And that improvement in communication could be the ability to point to stuff. And I'll tell you what, you can get a lot done with pointing. I'm a big fan of pointing. You hold up two things, you've got milk, you've got juice, which do you want? And the person can point to that. That's self-determination. That can improve quality of life or well-being. And that's communication. And I want to say that, we really need to pay attention to the members of our autistic community that don't have the average or above average cognitive abilities, because they are those that sometimes get lost. They may not be, talked about as much. And yet there's a lot of folks who do have the intellectual disabilities or the intellectual functioning that's lower than others. And we really need to make sure that we are improving their quality of life or well-being as well. And I think we've got some good questions to get to maybe, Chris. I'm seeing a bunch of them in here.
You're right. Yes. And the first question that I'm going to address is about the presentation today. There's a question about whether or not it'll be accessible once we are done. It will be accessible back at this link again. Give it just a little bit of time, but you will be able to access it for a pretty healthy span of time on demand, on top of the other assets that are part of the presentation. So we're going to go to the question and answer section, and we're just going to let's go ahead and hit the first one to come in, and then I'm going to jump back into some of the earlier questions. So, sorry, hold the window here. Actually, we're going to go to an earlier question. There are more and more non-speaking advocates that are able to share their lived experiences, and they are adamant they are not, and I'm just reading this directly, they are not IDD, but struggle with motor and speech. How could we better evaluate and support these individuals?
So I can jump in, Stephen, and then get your thoughts. I don't know. This is a controversial topic, actually, and it comes from the idea of something called the intact mind, where somebody has an intact mind and they have the cognitive abilities, but for whatever reason they can't express themselves in verbal language or sign language or some other kind of language. And this is certainly true. We see this in cerebral palsy. We used to think that people with children and adults with significant cerebral palsy who did not speak were all had intellectual disability. That is not true. And some of them can speak very well with computer assist or technology assist. Unfortunately, there has been something in the autism space that is under sort of the category of facilitated communication, sometimes called rapid prompting, now also spelling to communicate. All the research with autistic individuals that I've seen, and I've looked at this research and this has been written about, on the whole sort of category of facilitated communication, which includes things like rapid prompting, shows that the person who's really speaking is the facilitator or the helper, not the person with autism. So I think we have to be very, very careful about who is speaking. Who are we listening to? And I don't have a really good answer for how to, figure that out. I've seen some situations where it seems very clear to me that the person who's speaking is not the autistic person. And so I just want to be very careful, but I also want to be very respectful to people who feel that they're, that is the autistic person speaking. But I think that, we really do need to look at the research. You probably need to do maybe more research in this. But this is a controversial issue in the area of autism. And I don't know, Stephen, what you want to add?
I am passionate about I'm passionate in supporting what you just said about that particular population. But I'll take this a different way, which is, in having tested kids myself, which I'm sure you have too, Doreen, is like sometimes when a kid comes in who is autistic and doesn't, the presumption of IQ test is that you engage, that you try to do it. Mm-hmm. So, like let's say a school system gives someone an IQ test and the kid is autistic, they don't even try. It's like Doreen's in a coma. I give her an IQ test. Guess what? Doreen's going to fail the IQ test. She's in a coma, right? Because she's not engaging. The point is, like, you can have children who, if they just go by measurement of an IQ test, that child might have a very strong IQ, but doesn't perform well. So we have presumptions about how we measure disability as well, that you want to be that's why you need like information from everywhere, adaptive, everything to say, are they truly intellectually disabled or not? Another, though, is I have tested kids who are minimally speaking, and they have a nonverbal IQ in the 120, 130 range. It's like, and it blows your mind. It's like, how is that possible? And we do see that in autism. Those kids in the past, there is a bucket of kids in the past who we call diagnostic substitution, where they were, in fact, diagnosed then with cognitive disability, when in fact, now when we look back at them, they don't meet the criteria because they have a 120 or 130 nonverbal IQ, and they can do well with the right treatment. They can learn communicative devices, and over 70 or 80% of them learn functional communication, right? So I think there is a subset of kids who in the past, even in the 80s and so, who are diagnosed with a cognitive disability, when in fact, we're saying, well, they actually don't, they actually have autism instead. So, and that's different population from what Doreen's talking about with these kids who someone else is communicating for them. So,
Right.
Yeah.
Yeah, thank you so much for that. I think you're absolutely right about that. You just need to be really, really careful. And I always want to know, who am I hearing from? Who has the self-determination here? And the other thing I just want to add to this in terms of intellectual disability. Intellectual disability, is what it is, right? And if somebody has an intellectual disability, to assume that they don't is kind of disrespectful to who they are. That is part of who they are. That is part of how their brain works, right? And we can find all kinds of ways to have functional communication, to allow that person to, as much as possible, communicate. But we need to make sure that we know who is communicating.
I gotcha. Now there's a question here about genetic testing. So there's two-part question. What are the benefits of genetic testing after an autism spectrum disorder diagnosis has been given, and then would you recommend it?
Stephen, do you want to start?
Sure. I can just speak very concretely. In our clinics, we do. We recommend to every person they get genetic testing done. So that answers one part of the question. That doesn't answer the most important one, is why? Because why would you do that? One reason, again, is we have a presumption that all autism is, it's a behavioral phenotype that is the underlying biological problem is some type of genetic anomaly, and we want to identify that. But does it matter? Like if you have a child who behaviorally has autism and has all these difficulties and has challenges, who cares if it's a 15q.3 deletion or not, right? Like, what does that tell you? Well, it can tell you, it might not tell you much right now, but it can tell you a couple things. It can tell you if that is a well-known genetic disorder. It can tell you something about trajectory, course, treatments that you might not already know. In a more important way, it can also mean something for the family. So for family planning, for that person who grows up to be an adult, they might want to know, like, what is this? Do I pass along? Do I not? What is the genetic implication of it? It might mean something for the parent. There are many times where the parents then go get tests like, that came from me, that particular genetic line, it was heritable. So it can be important for family planning, for treatment, for knowledge. I think also just for understanding the child. To us, it's like it's this, autism is a behavioral diagnosis. So Doreen says they do, I say they don't. Who are you going to believe, right? We're both experts. But you can't deny the fact that this kid is a 15q deletion, right? So it becomes this real thing that you can hang your hat on. There's dangers associated with it. It's like, was it because I had that third cup of coffee in the trimester, whatever. It's not that at all. So we have to be careful and ethical on how we understand the diagnosis, how it's conveyed to people, and what it means. Doreen.
Yeah, I certainly agree. And it also helps that we're learning more and more. And I think about, something like 22q, a deletion on the 22nd chromosome, that is also associated with physical medical problems that need to be addressed. You're going to want to make sure that, you look at the child's heart, for example, if they have deletion on the 22nd chromosome. So it's helpful. It's not necessary for everybody. I will say for Fragile X, if a boy has autism and has Fragile X and he has a sister, that sister could not necessarily, she may or may not have autism, but she might not have autism, but she might be a carrier of Fragile X. She might want to know that, right, for her, reproductive future. So, but it's a personal thing. Some people say, I don't want to know, I don't want to, and I'm not going to do it. And of course, we want to respect that as well.
I gotcha. And now we have actually two questions here that'll kind of mold into one that are very specific, and there's some details that I'm not going to get into on the call specifically. Could an 18-year-old with a long history of ADHD who was never diagnosed with autism be diagnosed with autism? And where would that be attained if, the child is covered by insurance, but their MD doesn't feel like that would be necessary?
So they certainly could possibly have autism, or they possibly could have, more severe ADHD, or, we wouldn't know. I think sometimes people might have to push their doctors a little bit to get a referral. That happens. They might need to do that, but it's possible that an 18-year-old who was diagnosed with ADHD either has autism and not ADHD, or has autism and ADHD. And we wouldn't know that without an assessment. Stephen, I don't know if you want to add to that.
Yeah, I mean, my center here sees the full age range. We often do that, exactly what that person asked. And we actually accept self-referrals here. So like there are places you could go to do it. There's an interesting study out of Drexel that just came out. We had a talk on one of our webinars about TikTok diagnoses, right? There's a lot of people who are doing self-diagnoses themselves. But don't scoff. What was really interesting, what the study showed, was that half of the people who came in with a TikTok diagnosis actually had autism. The other half did not. So it's one of those double-edged swords that has given us a way to identify people and screen for people and find a reason, and then actually motivates them to go get a medical diagnosis if needed. But then also times people are just like, hey, I'm a little bit quirky, I must have autism, which they don't. And again, this is not in any way mocking an identity, which is different. If you want to identify as being autistic without a medical diagnosis, that's your right. But it's different. So yes, you can definitely be seen, diagnosed, and with all the proper tools.
And can I just add something, because I realized something that we may have been misleading in terms of the genetic stuff. It's a little off topic, but it actually relates. We were talking about major genetic disorders, but actually, most people that have autism or diagnosed with autism spectrum disorder do not have a major deletion or Fragile X or something like that. There are over 100 individual genes that have been associated with autism. So there's this whole other group that a genetic test is not going to be very helpful because we don't know enough yet. I wanted to make sure, because we were kind of I was kind of stuck on the major genetic disorders, but we don't want to say that everybody with autism has a major genetic disorder.
Can I sprinkle even more on that?
Yeah,
even there's 100 identified ones. There's about 600 contributory ones. We know it's a polygenetic disorder, but about 60% of the cases, we have no idea where it's coming from. And just to add this too, we do know that autism is the most heritable psychiatric disorder that we have in the books. So there are many reasons why we want to look at these things, but you're absolutely right. Yeah.
Gotcha. And so we're going to go ahead and wind down here. I want to thank everybody for joining us for today's webinar. I also want to thank Dr. Doreen Samelson, Catalight's Chief Clinical Officer, and Dr. Stephen Kanne, Director of the Center for Autism and the Developing Brain, and Assistant Professor of Psychology in Clinical Psychiatry at Weill Cornell Medical College and NewYork-Presbyterian Hospital, for partnering with us on such an essential topic. Please remember, download Catalight's latest white paper and take a minute to share your experience with us today on this webinar through the survey link in the resources widget. We appreciate your feedback, and they're essential to improving our future programming. I'm Chris Larson, and we'll see you guys next time.